Our next judge, Dr. Rupali Narlikar. Our next judge, Dr. Labsetkar Nikhil Arvind. And we will start the session with the speakers that we have. And even if it is not in the serial order, then whoever is present will present first. So is Dr. Akshay Mohan present? In that case, the second speaker is present, Dr. Payal Kathua.
Hello. Good morning everyone. I am Dr. Payal Khatua and I am going to present OCT biomarker changes in diabetic retinopathy patients after treatment with intravitreal ranibizumab. Diabetic macular edema is the main cause of vision loss in patients with diabetic retinopathy, and it can be divided into three categories: sponge-like retinal swelling, cystoid macular edema, serous retinal detachment. OCT biomarkers helps to identify ultrastructural alteration in the retina even before its clinical appearance. These biomarkers like disorganization of the inner retinal layers, that is DRIL, ellipsoid zone EZ and external limiting membrane disruption, presence of hyperreflective foci in different retinal layers, taut posterior hyaloid, that is responsible for recalcitrant macular edema. Objective is to evaluate whether qualitative and quantitative changes in retinal layer may affect treatment outcome in patients of diabetic retinopathy treated with intravitreal ranibizumab after 4 months of follow-up. We included 32 eyes of 26 patients with NPDR and 0.5 mg of intravitreal ranibizumab given as per treat and extend protocol. OCT images pre-injection, post-injection monthly for 4 months were taken, and retinal parameters were evaluated on horizontal OCT images within 3000 micron diameter from the foveal center. And then we measured CMT, central macular thickness, subretinal fluid, intraretinal cystic space, disorganization, that is DRIL more than 50%, EZ, ELM, whether they are intact, partially disrupted or completely disrupted, and hyperreflective foci more than 15 taken as positive. Coming to the result, 44% patient belong to severe NPDR group, 56% belong to moderate NPDR group. And changes in DME parameters, we can see SRA became nil after 4 months of intravitreal treatment, and rest of the DME parameters also decreased, decrease was significant. DRIL also increased after 4 months, HRF decreased after 4 months, and these changes were significant, whereas taut hyaloid and ELM disruption was changed but not much significant, and EZ disruption after 4 months also found significant. And coming to the visual acuity, patients who have SRF and HRF at the baseline showed corroborated with better visual outcome than the patient who do not have these parameters, whereas ICS, DRIL, EZ and ELM disruption present at the baseline, then patient corroborated with poor visual outcome than patient who have the biomarkers. Coming to other studies like Nagai and et al. Found that high area ratio and large number of ICS at the baseline, these predicted worse visual outcome at 12 months. Like my DME parameters, Kadzirali et al. Also found that significant improvement in retinal thickness as a whole and in individual retinal layers after anti-VEGF treatment in DME. And also in HRF, like my study, Huang CH et al. Found that patient with higher number of HRF in the outer retina had enhanced visual improvement at the 1 year of follow-up after anti-VEGF treatment. So we can conclude that OCT biomarkers of the inner and outer retinal layers are the predictive markers for visual outcome and useful in objective monitoring of the treatment of diabetic retinopathy. Limitation of my study is small sample size and a limited duration. These are my references. Thank you.
Questions can ask. Good presentation, ma'am. In cases of non-responsive, have you tried for steroid injections?
No, I have not.
Not concerned with
No,
this study?
no, no.
Okay.
And how many injections did you, was this at the end of the first injection?
No, I have given as per treat and extend protocol. So some patient required 4 injections, some patient required 2 or 3 like this.
And what was your cutoff at when you assessed these? How many months from initiating treatment? Or
4 months.
4 months.
4 months.
So some people might have had more injections.
More
and some
injections,
less.
some less.
And there was no supplemental treatment of any other kind given, like laser or anything?
No, I have only taken moderate and severe NPDR, so I have not given laser.
But for the macular edema, no further.
No, I
grid
have
or
only
focal.
taken consideration intravitreal ranibizumab, and those patients require laser we have done out afterwards, but we have not taken
included
in this
in them.
included.
So, but treat and extend was right from the start of the.
Yes.
Fine.
And the vision was checked on?
Every
Yes.
visit, and we
No, using the ETDRS chart or the
no
Snellen?
Snellen's chart.
So, thank you,
Thank
Dr. Payal. And next speaker is Dr. Pranav Kansal. Is he there? He's not there?
Naman Sani? Come. नहीं है ना? No.
Good morning, the judges. I'll be presenting today on the topic on evaluation of ganglion cell complex for early diagnosis of diabetic retinopathy with OCT. Now, with increasing time and these days modalities, the diabetes mellitus has increased, and there is a estimated prevalence of more than 400 million people worldwide. The prevalence of diabetic retinopathy is 16.9% prevalence. Of vision threatening diabetic retinopathy is 3.6%. According to the WHO, 72.96 million of the adult population in India have diabetes. Now, experimental studies have shown that damage to the retinal ganglion cell occurs in diabetes. This suggests that pathogenesis of diabetic retinopathy is based on the neural components. Then, the ganglion cell complex is defined by the innermost layers of the retina, which comprises of ganglion cell layer and the inner plexiform layer. Our goal was to use the OCT and find the thickness of the ganglion cell layer in the patients. The optical properties of the inner retinal layer can provide useful information to differentiating diseases and healthy eyes. Diabetes is known to cause thinning of the retina before the onset of the severe diabetic retinopathy, which is most associated with neurodegeneration. Then materials and methods which we used. Our study was case control study in which it was conducted in the outpatient department. Then we took the tool of OCT in examining the ganglion cell complex at the area of the macula. Now, our inclusion criteria were normal healthy individual in that age group, then patient with diabetes without diabetic retinopathy, and patient with diabetic retinopathy. In this, we included only the early diabetic retinopathy, only the NPDR patients. And then exclusion criteria was intraocular pressure more than 21 mm of mercury, then those showing evidence of any field effects, then hypertension, diabetic macular edema, and high myopia. And then we included the performers. We examined the patient on the Series 500 OCT. In this, it measures only the inner plexiform and the ganglion cell layer. It does not include the RNFL layer in these parameters which we checked. And then the results which we saw, that the mean age of the patients among the diabetics were 56.1, plus minus 11, and there were 28 males and 32 females in the study. And then this is the chart showing the various sectors in which the thinning can be seen, like in the superior, supranasal, supratemporal, and the inferior temporal region. Now this is these were the different results which we got, like in superior, inferior, supranasal, supratemporal, and inferiotemporal thickening. Thinness is seen in the patients with diabetes as compared to diabetic retinopathy and non-diabetic patients. Like in this, the chart in the first picture, we can see the non-diabetics in the blue and the diabetic patients in the orange. So in this, we can see, as compared to the studies, there was thinning compared in all the diabetic patients compared to non-diabetic or normal individuals. Now in this, we compare all the three parameters, like non-diabetic patients, diabetic patient, and the diabetic retinopathy patients, in which we can see that diabetic patients had comparatively early detection, due to which we can do, like in cases of diabetes, if you can see, like in the inferionasal quadrant, 73.10 was the rating, and our conclusion was it was seen that inferior sector of the OCT, the thinning was the most, and the superior sector had the most thickening. Thank you.
So any difference with glaucoma cases?
No,
About
ma'am.
the thinning?
The glaucoma cases were excluded in our study. We
Yeah.
did not include the glaucoma.
Okay, you've excluded those with a
Yeah.
visual field defect.
Visual field defects and the IOP more than 21 mm.
Correct, but you've not really looked at the RNFL.
No.
Okay, because that typical inferotemporal loss is very common in glaucoma. Your other finding, which is difficult to explain, is you're saying it is early diagnosis, but
Yes, ma'am.
yet your retinopathy patients do not have as much loss. So
Retinop-
you're going to diagnose a retinopathy, but then the retinopathy is going to have normal thickness.
No, ma'am. The retinopathy also had a decreased amount of thinning, but we can see that if we are diagnosing using OCT, we can, before any changes like any perivascular changes, there will be thinning seen.
In the RGC.
Yeah, in the
Correct.
retinal ganglion
So,
cells.
correct, right? So which means that in a clinical retinopathy, you are
Yeah.
seeing thinning.
Yes, ma'am.
But then in a diabetic retinopathy, that much thinning is not seen. They already have that is what your
Yeah.
results are.
Yes, ma'am.
Which is
Almost
conflicting.
comparatively, yeah.
Right? So your normal patients and your diabetic retinopathy patients are running similar. Just that you have a bar diagram.
I'll just get.
Right? Just go back
Ma'am,
to that.
Can I have the presentation, please? Like, ma'am, in this,
No, this is somebody else's. Huh.
like in this picture, we can see, like in the inferiotemporal quadrant, if the last we can see, there is thinning in the diabetic retinopathy as well as in the in the
Agreed,
normal
but
diabetics.
what you're getting is more that the diabetic retinopathy and the normal patient, that is orange and the grey, are running more hand in hand than the blue, which is the
Yes, ma'am.
pre-diabetic retina.
No, non-diabetics. Those are
Non-diabetics.
non-diabetics. All the
Correct, but
blues are
what you're saying is they're pre-diabetic now. Pre-diabetic retinopathy, predicting them on the basis of your RGC.
Ma'am, the diabetic patients, we included the diabetic patients and the non-diabetic. Non-diabetic we took as a control. Then we diagnosed, we saw that diabetic patients had thinning, and similarly with diabetic retinopathy. So we can see that if we are going to predict for diabetic retinopathy, there will be thinning earlier, which can be seen.
Okay.
Thank you, ma'am.
Thank you so much.
Thank you, sir.
Next speaker is Dr. Akshay Mohan.
Good morning, everyone. Good morning. Today I am going to present on the topic how raised serum cortisol and VEGF levels correlate with severity of diabetic retinopathy. Now, as we all know, hemodynamic changes in diabetic retinopathy occur as a result of altered ocular blood flow, which occurs due to hyperglycemia, rheological changes, tissue hypoxia, endothelial dysfunction, and pericyte loss. In patients with type 2 diabetes mellitus, hyperglycemia and insulin resistance leads to oxidative stress, which causes inflammation and apoptosis of retinal ganglion cells and inner retinal capillary endothelium, which leads to changes of diabetic retinopathy. Hyperglycemia insulin resistance is governed by hormones like cortisol and growth hormones, and apoptosis mediated through growth factors like VEGF. In our study, we took age group of 40 to 65 years, in which there were 46 cases of diabetes mellitus and 15 healthy controls. Should I restart? In our study, we took age group of 40 to 65 years, in which there were 46 cases of diabetes mellitus and 15 healthy controls. The cases of diabetes mellitus were divided into 3 groups: no diabetic retinopathy, non-proliferative diabetic retinopathy, and proliferative diabetic retinopathy, as shown here. Informed consent was taken from all the cases, and study was done in Department of Ophthalmology, KGMU Lucknow, in duration of 1 year. Under ocular examination, we did best corrected visual acuity through logMAR, slit lamp and fundus examination was done, and SD OCT was performed. Under blood sample analysis, we checked human VEGF assay through ELISA and serum cortisol levels through chemiluminescence microparticle assay method. Blood sugar levels, HbA1c and hemoglobin levels were also measured. This table here shows demographic biochemical parameters, cortisol and VEGF levels of 4 groups, which clearly states that serum cortisol and VEGF levels were significantly increased in non-proliferative and proliferative diabetic retinopathy groups. Mechanism of action of cortisol are linked to hyperglycemia and insulin resistance in diabetic patients. Oxidative stress, growth factor, and hormonal imbalances linked with pathogenesis of diabetic retinopathy leads to activation of mitogen activated protein kinase that plays a role in form of signaling component for VEGF and as a regulator of endothelial cell permeability. Our study demonstrated that serum levels of VEGF and cortisol increased significantly as the level of retinopathy increased from diabetes with no retinopathy to proliferative retinopathy. This study has highlighted for the first time that serum cortisol and VEGF levels are significantly increased even before the signs of diabetic retinopathy develop in patients with diabetes mellitus. With this, I would like to conclude my topic that raised serum cortisol and VEGF levels correlate significantly with severity of diabetic retinopathy. Thank you.
Can you just go back a few slides to that chart where you show a comparative? Just stop there. And you were saying that there is a higher HIC correlating with the severity.
Yes, ma'am.
Right?
As the severity increased, the cortisol levels were increased.
Correct. But as a predictor, you are saying in diabetic retinopathy.
Yes,
so where will you put off your cutoff as what is your normal cortisol
ma'am,
level? Because
we did ROC curve for cortisol in which the cutoff was 9.5.
9.5. And for the VEGF?
Ma'am, VEGF the cutoff was 300 plus minus 10.
Correct. So which means that if you look at the levels at the bottom, the VEGF is not showing such a big difference in the non-diabetic retinopathy, but the cortisol level is a better predictor, correct?
Yes, ma'am.
That's what you're saying, that VEGF rather, cortisol is better predictor than VEGF.
Ma'am, both are good predictors, but maybe if we do with large sample size, the difference will come more.
Correct.
So, thank you, Dr. Akshay.
Thank you, ma'am. Thank you, sir.
And this is a one-time snapshot that you've taken, right? Have you tried to see them serially to see how it behaves in terms of if their diabetic control is improved or their systemic situation changes, whether the...
No, ma'am. It is a one-time.
It's a one-time thing.
Thank you. Our next speaker is Dr. Pranav Kansal.
Good morning, everyone. So my study was to find out the relationship between IL-6 and IL-10 and its correlation with vitamin D in posterior segment diseases of the eye. So as we know that there's a substantial burden of posterior segment diseases leading to low vision all over the world. Current treatment regimens of such diseases entail the use of costly anti-VEGF intravitreal injections given several times to achieve an acceptable decrease in disease activity. Use of laser photocoagulation has its own set of side effects apart from availability which limits its use. Leaving behind a lacuna in the treatment of the disease management to be filled by other potential therapies. So the present study investigates the legends surrounding vitamin D and its multimodal effects in the eye, specifically the posterior segment diseases. So few studies have shown the anti-inflammatory effect of vitamin D on the body attributed to its steroidal mechanism of action, and have thus suggested a potential therapeutic role in diseases which involve inflammatory pathways. And several studies have highlighted the inflammatory processes in play in a majority of these posterior segment diseases, especially diabetic retinopathy, age-related macular degeneration, retinal venous occlusions, and uveitis. So this was a case-controlled study conducted on 93 patients presenting to our OPD, and institutional ethical committee clearance was obtained. Patients were segregated into group A, comprising of 60 patients, which had posterior segment diseases, and group B, 33 patients comprising of age and gender matched healthy controls. The exclusion criteria was any systemic inflammatory disease, any autoimmune disease, history of retinal laser photocoagulation, any intraocular surgery, use of steroids, oral or any oral vitamin D supplementation in the past 3 months. A detailed history and examination was done. Fasting blood samples were collected in K3 EDTA tubes, and plasma was separated by centrifugation. IL-6, 10, and vitamin D estimation was done using ELISA kits. Statistical analysis was done using SPSS 21, and p-value of less than 0.05 was taken as significant. So out of the 60 patients in our study group A, patients with diabetic retinopathy formed the majority of the patients, followed by retinal venous occlusion patients, ARMD, uveitis, and Neal's disease. So we found that plasma vitamin D concentration was found to be significantly lower in diseased participants as compared to healthy controls, and this turned out to be statistically significant also. Similarly, plasma IL-6 concentration was found to be significantly higher in the diseased participants as compared to healthy controls. It was also observed that we took out a correlation, but it was statistically insignificant. Serum IL-10 was also statistically higher, and its correlation came out to be statistically significant. So in conclusion, our study showed a higher level of plasma IL-6, IL-10 in the posterior segment diseases, indicating a possible inflammatory mechanism in the pathogenesis of these diseases. Vitamin D is known to have an anti-inflammatory effect among various other effects in the body. The negative correlation between vitamin D, IL-6, and IL-10 may be used as a possible target in therapeutic regimens as a measure to decrease the financial burden on the patient by possibly decreasing the number of anti-VEGF injections. That's all. Thank you.
So whether there was any gender differences in vitamin D levels, or have you seen?
So we did not. It is something that the data is there. It is something that to be analyzed. But in general, we saw that the overall population was a little on the lower side of the vitamin D levels, but the diseased population was significantly lower. Like they were almost like 10-15 points lower.
No, I am asking about the male to female ratios.
Yeah, so that is the data is there. That is left to be analyzed.
Okay.
When exactly did you do this study?
Ma'am, it was done during my MS time from 2018 to 2021.
Yeah, the reason I'm asking is that a lot of patients during COVID times had a lot of these inflammatory biomarkers and
Yes,
D3 going haywire, and they persisted much later after the COVID
So ma'am,
episode.
this was one thing that so a lot of papers were coming out regarding the role of vitamin D. So what we did, and we were little free at that time because academic activities were all stopped. So we called some of our patients, and we got to know that inflammatory markers, vitamin D levels were kind of relating to the morbidity and mortality. So it's just a random fact, but none of our patients lost their lives which we contacted. So that was one thing, and all the patients. So we had also supplemented vitamin D later to find out the effect, and that is again data that needs to be
analyzed. Yes.
analyzed.
But so you did not ask any of these patients whether they had a history of COVID infection in their past,
Ma'am,
clinical or subclinical.
So COVID infection was our sample collection was completed by almost like 2019, and it was.
That's what I asked you. When was this the sample
so,
thing? Before pre-COVID.
It was pre-COVID, ma'am. Okay. Thank you.
Thank you.
Thank you. So the next speaker is Dr. Richa Kamal.
Good morning, seniors and colleagues. First of all, I would like to thank AIOS for giving me this opportunity. My topic for study is to evaluate the association of drill with visual acuity in center involving diabetic macular edema. So first of all, what is a drill? It is disorganization of the inner retinal layers, that is the horizontal extent in microns for which any boundaries between the ganglion cell inner plexiform layer complex, inner nuclear layer and outer plexiform layer could not be identified. So drill acts as a predictive biomarker, acts as a tools to enhance patient counseling, improve risk stratification, advance clinical management, influence selection of eyes for clinical studies targeting DME. So histologically, it actually represents disorganization or destruction of cells within the inner retinal layers, including bipolar, amacrine and horizontal cells, leading to disruption of pathways that transmit the visual information from photoreceptors to the ganglion cells. So my aim of study was to evaluate the association of disorganization of retinal inner layers with visual acuity and their corresponding changes with time. So objective was to check the extent of drill, to evaluate visual acuity at baseline, 4 months and 8 months follow-up, and to assess the association of drill with visual acuity. So it was a single center prospective observational study, 45 eyes of 34 different patients with center involving diabetic macular edema in a tertiary eye care center in Kolkata from December 2020 to July 2021. Inclusion criteria was diabetic macular edema and cases where all the data were available for baseline 4 months and 8 months. Exclusion criteria was any history of ocular surgery within 6 months of study or any other ocular comorbidities or if the data was not available. So proper history was taken and standard ophthalmic examinations were done, and at baseline 4 months and 8 months of follow-up, we checked for BCVA, OCT to check for the extent of drill, to assess the association of the drill with visual acuity and presence or absence of CNP areas in association with drill. So a total of 45 eyes were evaluated with mean age of 67.38. Female male was 10 and 35 and laterality was 28 right eyes and 17 left eye. So on baseline, the BCVA was around, mean BCVA was around 0.64. At drill, mean mean drill was 575. At 4 months, mean BCVA 0.7 and a drill increased to 690. So there was a decrease in BCVA corresponding to increase in the drill value. And at 8 months, there was decrease in the drill and corresponding there was improvement in the visual acuity seen. That has a significant p-value. And the percentage of the CNP area was present in 31 eyes out of 45. So the center involving drill is closely associated with visual acuity in center involving DME, and changes in drill extent correlates with changes in visual acuity. Drill seems to be a good predictive biomarker for visual acuity outcome in center involving diabetic macular edema, and our results correlated well with the parent article of Jennifer K. et al., where for every 279 to 350 microns increase in drill, there was a corresponding decrease in BCVA by 1 line. So limitation is a small sample size and small duration of study, and other parameters like hyperreflective dots, SRF and intraretinal fluids, they should have been included, and subgroup analysis of association needs to be done, and correlation of OCT drill extent and CNP area seen in the OCT could have been done. So conclusion is drill is a good predictive biomarker for visual acuity outcomes in center involving diabetic macular edema, and OCT evaluation is a must in DME for prognosis and counseling of visual outcome. Thank you.
So does it improve? The disruption improves with treatment?
The drill extent at times, no ma'am. Actually, it depends upon case to case, and there, if the drill extent increases, that corresponds with the worsening of visual acuity. Even though there was decrease in SRF or IRF, but if the drill was increasing in size, there was a corresponding decrease in visual acuity seen.
Yes, but in one of your slides, you showed that the drill extent decreased and the visual acuity improved. So what I was asking, yes, there is one. So I just wanted to know whether it is possible for a disorganization to recover.
Yes, ma'am. It can recover. Drill can actually recover, but corresponding visual acuity changes can be seen along with it.
Fine.
So any relationship with HbA1c and the blood sugar level?
Ma'am, that
That
we
you
did
have
not
not
see.
done. Okay, thank you.
Thank you.
So next speaker is Dr. Yusra Asad.
Good morning, everyone. I'm here to present my paper on intravitreal anti-VEGF in silicone oil-filled eyes, and especially in patients of polypoidal choroidal vasculopathy. We have no financial disclosures. So as we all know, PCV is an important cause of visual loss in elderly and is characterized by characteristic polypoidal or aneurysmal lesions with or without a branching vascular network. It was considered a subtype of neovascular AMD at first. However, now we know that there are significant variations. So to look at PCV, we could see it as massive subretinal exudation in the retina. It could also present as large subretinal hemorrhages or even a breakthrough hemorrhage, and could be of central, peripapillary or peripheral type. The gold standard of investigation is indocyanine green angiography. However, typical features are also seen on OCT, which have been documented. When it comes to treatment of PCV, it is two-pronged. One is the treatment of the cause, such as laser when polyps are present in the safe zone. PDT, however, there is an issue of availability of verteporfin, anti-VEGF, or a combined PDT and anti-VEGF, alongside the treatment of associated findings, such as if there's a large subretinal hemorrhage, we may need to do a pneumodisplacement. An old hemorrhage would require a tissue plasminogen activator injection alongside, and if there is vitreous hemorrhage, we may need to do a PPP with a hyaloid peel with or without the injection. However, post-operatively, do we need to treat the cause, and how? So this is a first case. This is a patient, a middle-aged male, who presented to us with diminution of vision in the right eye. There was vitreous hemorrhage, as can be seen here, which was confirmed on ultrasonography, and the patient was taken up for pars plana vitrectomy. Upon clearing up of the vitreous hemorrhage up to the extent possible, we thereafter did a close base shave, removed whatever vitreous we could, and then took a 38 gauge cannula with tissue plasminogen activator and injected tissue plasminogen activator subretinally. In this case, as you can see, large bullae of subretinal blood here. This is the tissue plasminogen activator injection. This was followed by a fluid air exchange and then silicone oil injection. So while the silicone oil was present in the eye, we continued to give the patient multiple injections of intravitreal aflibercept at 1 month intervals so as to facilitate drying up of the retina and ensure quiescence of the underlying disease process, as you can see here, and the retina is progressively drying up. This is the post-operative picture of the patient with a stable retina after silicone oil removal and cataract surgery combined. This is yet another case of another patient who presented with vitreous hemorrhage. And again, multiple injections of aflibercept were given. And a patient who was already under treatment for PCV, however, presented with breakthrough vitreous hemorrhage, was taken up for pars plana vitrectomy with silicone oil, along with, again, serial injections of intravitreal aflibercept. So this is not the first instance. We have quite a few reported instances in literature of anti-VEGF in silicone oil-filled eyes. However, they have been given for choroidal neovascular membranes and PDR. However, we can do a similar treatment for eyes of PCV to ensure the regression of polyps, because it is important to remember not just to remove the hemorrhage and clear the media and allow the retina to settle, but also we have to prevent recurrences and treat the basic pathology alongside, which in this case is by using multiple intravitreal anti-VEGF injections. Thank you.
How frequently were the injections given?
Sir, at 1 month intervals. And those patients who were already on treatment were eventually taken up for treat and extend protocol as and how their protocols were.
And what was the visual acuity outcome?
So, ma'am, for patients who already had scarring, the visual acuity was similar in the range of 660 or finger counting. However, one or two of our patients have done really well, and they are doing they are at about 618 or 636. The first patient that I showed you was at 636 visual acuity postoperatively.
Whether the half-life changes after the vitrectomized eye?
So, sir, there are studies in which the half-life has shown to be less. However, all these patients who were injected with anti-VEGF in patients of choroidal neovascular membranes, they were shown to have a similar effect and were injected at 1 month intervals only in all the other instances that we have found in literature.
Thank you.
Thank you, sir.
So next speaker is Dr. Neha Shah.
morning, everyone. So my topic is RNFL and ganglion cell thickness as an early marker for diabetic retinopathy. So my aim was to evaluate a diagnostic test which can detect changes in the neurosensory retina and serve as a biomarker to identify the patients as a risk of developing diabetic retinopathy, and to establish the role of OCT in evaluating the RNFL and GCC, which is the ganglion cell complex thickness, in diabetics without any retinopathy, and comparing it with their age-matched normals. So this was conducted as a tertiary care hospital in the Department of Ophthalmology, a cross-sectional observation study in which OCT ONH RNFL and OCT macular cube was conducted for both eyes of patients with diabetic mellitus, but no diabetic retinopathy changes, and their age-matched normals, that is, they had no diabetes. The ganglion cell complex and the RNFL was compared, and it is a cross-sectional observational study. It was for a 6 months duration, and the population was, as I said, diabetic and non-diabetics. The inclusion criteria were age more than 30 years, patient with type 2 diabetes without diabetic retinopathy. Exclusion criteria were any systemic disease other than diabetes, diabetic retinopathy or any other retinal pathology, previous laser photocoagulations or any injections, history of ocular trauma, high myopes, blurred ocular media, or glaucoma, which was an intraocular pressure more than 21 millimeters of mercury. So how we went about was every patient that came into the OPD, if we could fit into the inclusion and exclusion criteria, BCVA slit lamp, applanation tonometry, and a dilated fundus evaluation was done. OCT was done, and then they were divided into groups based on their blood. We got their blood investigations done, and then we decided whether they are diabetic or non-diabetic, because many patients that come to our OPD, they are not aware that they are diabetics at all, and then their matching and analysis was done. These are the OCT scans showing the RNFL in the 4 sectors and GCC in the 6 sectors. So what we found was the RNFL in the 2 groups, in the diabetics and the non-diabetic, had significant difference. This RNFL is parapapillary and it is not macular. Where in the parapapillary also we saw that there was a significant difference, and the comparison was done by independent t-test, and there was the p-value was less than 0.001. As even can be seen in the graph comparatively, where the above graph is of the diabetics and the below one is of non-diabetics. Even similarly in the ganglion cell complex, in all the 6 sectors, it was seen that there was significant difference between diabetics and non-diabetics. We included 220 patients, 110 in each group, and they were all gender matched also. There were equal number of females and males. So as per the above, we deduced from a study that there is a significant difference in the RNFL in all sectors in age and gender matched diabetics and non-diabetics. Similar studies were conducted by Afif et al. And Pekel et al. And even they found that there was significant difference, but they found that there was, like in the Pekel study, there was significant difference in RFL only in the superior and the nasal quadrant. And the Malif study, they found that there was a significant difference in the average, superior and inferior. They did not find much significant difference in the nasal and temporal. Similarly, in the ganglion cell complex, there was a significant difference in both, but in the one study they found that there was only difference in superior nasal, and the other that was found that there was significantly decreased in all 4 sectors. So in conclusion, the exact cause of this thinning in GCC and RNFL is still not known, but it seems to be occurring due to lower perfusion and higher demand of the inner retinal layers, which leads to these systemic changes. Another potential mechanism is the decreased availability of insulin, which is a survival factor for the retinal neurons, which is counteracting the apoptosis of the neuroglial cells in the inner retina, which induces which is inducing hyperglycemia and advanced glycation of the products. Hence, for early detection of diabetes-induced vasculopathy, rather than just dilated fundus evaluation, an OCT examination of the ganglion cell layer and the RNFL should be done. Thank you. We are looking forward to do this, their follow-ups after every year. So we'll come to know whether how early they are developing diabetic retinopathy.
Any, in which case you should do it in 2 segments, one which the diabetic control was good and in which it was not good.
Ma'am, no, we have done it in people who do not have diabetes at all. We did their FBS, PPBS and HbA1c of all the patients. So only in people who were confirmed non-diabetics were matched with people who were diabetics
No,
but
no,
did
I
not
understand.
have.
That is your current study. What
Yes,
you're saying
ma'am.
is in the follow-up, if you're planning to prove that it is diabetic retinopathy is related to the progressive thinning, then you
Yes,
have to have two subgroups where you can explain
Early
uh,
diabetics and
yes.
yes, ma'am.
And also whether your theory that it is ischemia which is causing a problem, then in which case the other corroborative
Factors have been, yes, ma'am.
should
Yeah,
also be looked at.
Thank you.
Thank you. Next presenter is Dr. Farhina.
Shall I start? Okay. Good morning, everybody. The topic for today is the relationship of vitamin D, vascular endothelial growth factor, and pigment epithelial drive factor in posterior segment disease of the eye. So the aim was to study the plasma levels of VEGF, PEDF, and vitamin D in posterior segment disease of the eye. This study was conducted on 93 patients. Patients were segregated in Group A and Group B. Group A comprising of 60 patients and Group B 33. Group A mainly patients with disease of posterior segment of the eye, and Group B age, gender, healthy, control matched. Any systemic inflammatory disease, any autoimmune disease, history of retinal laser photocoagulation, any intraocular surgery or use of corticosteroids or oral vitamin D supplementation in the past 3 months were excluded from the study group. Detailed history examination was done, fasting blood samples were collected, and VEGF, PEDF, and vitamin D estimation was done using ELISA kits. So out of the 60 patients in the study group, patients with diabetic retinopathy formed the majority, followed by RVO, age-related macular degeneration, uveitis, and Eales disease. So plasma vitamin D concentration was found to be significantly lower in the disease participant because compared to healthy control. As we can see in this chart, group A comprising of 16.79, and in group B it's 24.87. Serum VEGF was found to be significantly higher in disease participants, being 235, and in as compared to healthy controls, 99.14. Serum VEGF was found to be negatively correlated with the serum vitamin D level, and this correlation was statistically significant. Serum PEDF concentration was found to be significantly higher in disease participants group, 14.24, and as compared to healthy control, being 8.22. Serum PEDF levels were found to be negatively correlated with serum vitamin D, and this correlation was also statistically significant. So oxidative stress affects the RPE, leading to the development of vascular eye diseases. Vitamin D is known modulator of oxidative stress and angiogenesis. Vitro study was done in 2020, which was carried out to evaluate the protective role of vitamin D on RPE cells. Murugeshwari et al. Observed that vascular signaling modulators such as VEGF and Notch were reduced in hyperoxic condition, but significantly upregulated in the presence of vitamin D. These findings may give impetus to the potential of vitamin D as a therapeutic agent in hyperoxia-induced retinal vascular diseases. So Lu et al. In 2018 conducted an animal study based on evaluate the mechanism underlying the effect of vitamin D on diabetes-induced retinal vascular damage. And they also conclude vitamin D decreases diabetes-induced loss and exerts the protective effects. In our study also, it has been seen that vitamin D was significantly decreased and VEGF and PEDF was increased in posterior segment disease, thereby indicating a possible angiogenic pathogenesis. Lower vitamin D levels were associated with higher level of VEGF and PEDF, and that is, they were negatively correlated. So key message is vitamin D may act as a novel target for therapy in disease of the posterior segment of the eye. Thank you.
So you recommend that all patients should be given vitamin D?
Not all patients, ma'am, but it has been seen like in early in the disease, the levels are, it can exert a protective effects.
Okay.
Your patients were from 2020, right?
Yeah,
Your
from-
studies.
yes.
So have
Pre-COVID.
yeah, and any changes in the response or the performance of the disease subsequent to vitamin D supplementation?
We have not
Not really
yet,
analyzed
yes.
that.
Yes, this is a
Because
cross-section.
because you have a lot of different kinds of common final point might be an inflammatory component,
Yes.
but the different diseases have different other components,
Also,
and therefore
yes,
the
ma'am.
vitamin D should have
Give-
different.
Yes, ma'am. No. Thank you.
So next presenter is Dr. Mohammad Azimuddin Malik. Is he there? So he's not there. Okay, so I call upon Dr. Samiksha.
So, good morning everyone. I'll be presenting on the real world results of newer intravitreal anti-VEGF biosimilar in North India. Slides are not moving. So to know about biosimilar, we need to know what's biologic. They are therapeutic agents containing proteins derived from living organisms. They are large complex molecules and they are made by cell line growth media, post-translational modification, purification processes. So biosimilars are actually biologics, but they are not the copies of existing reference biologic, and they aim to mimic the therapeutic endpoint. They are made by reverse engineering work and phase 3 trials, and they should prove pharmacokinetically, pharmacodynamically, immunogenicity-wise, and safety and efficacy-wise similar to innovator biologic. So as we all know that the original biologics like Lucentis by ranibizumab, aflibercept and bevacizumab, the US patent has already expired and Europe patent is also expiring. So the newer anti-VEGF biosimilars have been making round in Indian market, and we all know that the data of razumab is already there since 5 years. So the recently launched newer biosimilar by siplapizumab, we have done study on that, and there is no financial disclosure. So we gave vizumab in cases of diabetic macular edema, CNVMs, and retinal vein occlusions. So the study period was from July 2021 to April 22, and we gave around 125 injections in 100 of our patients. There were around 75 males and 50 females, and the main age group was 56 years. And 1 month follow-up was done for all our patients, and 6-month follow-up was done for 45 patients. And so these are a few of our case examples, and we see that this was a case of diabetic retinopathy with hypertensive retinopathy mix, and we see that there was resolution of subretinal fluid within a month. Then again, this was a case of vein occlusion. We see that even with 1 injection, there was resolution of edema, and this was a case of CNVM where we see that there is resolution of subretinal and intraretinal fluid. So the outcome, we saw there was good safety outcome, and the efficacy was good in terms of morphological and visual outcomes. So to conclude that the newer biosimilar, it is cost efficient obviously, and they are safe and effective, and they are approved for most of the use as original biologics. There was obviously there is good, it is a single use vial, and there is no problem of fractionating or pooling of patients, and although longer term studies with larger patient population is required for the newer biosimilars, as more patents are expiring in coming decades, significant shift is seen towards the biosimilars. They are safe and low cost therapy for macular diseases in developing countries like ours. And it is important for clinicians to have a clear understanding about the ophthalmic biosimilars before the industry brings these molecules to the mainstream clinical use globally. Thank you.
Any adverse drug reaction?
No, sir. None of our patients we saw that.
Only a single injection was given.
Yes, a single injection in which we saw that there was resolution of fluid. We have repeated for 25 injections. We have like 100 patients, we gave 125 injections. So yeah, it was done. 25 patients, we repeated the injection also.
Okay.
So it appears that response is better than the original molecule?
No, ma'am. Actually, we didn't compare as such. We just saw that it has a good efficacy and it is a good substitute. We are not comparing it with the original molecule just because the patent is expiring and we have no other option as such. So that's why we did it. Thank you.
6 minutes. To the end of the session. Thank you very much, and all the speakers were very good. Heartiest congratulations to them, and thank you for patient hearing. Thank you so much.